Hello, everybody. Um, Eastern Mediterranean and African webinar, which will be dealing today with neuropsychiatry and epilepsy. And we are pleased and honored to have Dr. Haytham Tayyib as our first speaker. Dr. Haytham Tayyib is an associate professor of neurology, neuropsychiatry, and clinical neurophysiology at the King Abdulaziz University Faculty of Medicine. He completed a neurology residency at the Montreal Neurologic Institute at McGill University, followed by 2 fellowships, one in neuropsychiatry and behavioral neurology, and another in clinical neurophysiology with a focus on epilepsy. He currently serves as the head of the epilepsy unit and the chief of the neuroscience research unit at King Abdulaziz University. Dr. Haytham Tayyib, the floor is yours.
Thank you so much. It's a great pleasure to be here and share this platform with everybody. I just want to make sure that we have my screen up. And the topic today is epilepsy neuropsychiatry, as Dr. Manal mentioned. Hopefully my talk and the next talk will complement each other. My talk will focus on practical insights related to actual cases and hopefully will translate some of the aspects that may be less imaginable to those who don't directly deal with these cases. I will begin with presenting an overview, a map of relationships between neuropsychiatry and epilepsy, a relationship that's been well recognized for many, many years, since the days of Hippocrates and Jackson. We'll use cases to illustrate. We'll discuss ictal and post-ictal psychiatric symptoms. We'll discuss the effects of medicines and surgical treatments in epilepsy. All right. The story in neurology always begins with a lesion. Lesions lead to epilepsy. And it so happens that the brain regions, the localizations that lead to epilepsy, are also instrumental in regulating mood and behavior and cognitive functions. Temporal and frontal lobes are prime examples. So therefore, the lesion that leads to epilepsy oftentimes also leads to neuropsychiatric and or cognitive symptoms. So here comes the first relationship between epilepsy and neuropsychiatry. Seizures are the next point of relationship. Seizures, either ictally or post-ictally, may lead to neuropsychiatric symptoms. Ictally because of the seizure-related changes in neurophysiology, and post-ictally because of dysfunction in brain regions after seizures before they return to their normal interictal state. In the interictal state, there are changes that happen. Brain electricity and neurophysiology may not be as normal as those who don't have epilepsy. And this may present with psychiatric symptoms, once again, because the brain regions are shared. We treat epilepsy with anti-seizure medications, many of which have psychiatric effects, positive and or negative. We use surgery or other interventions, and these also have alter neuropsychiatric outcomes. The flip side is also true. We treat psychiatric symptoms and psychiatric diagnosis with psychoactive drugs, and these alter seizure threshold and may cause an acquired form of epilepsy or provoke epilepsy. And there are other interesting manifestations and overlap between neuropsychiatry and epilepsy, including non-epileptic seizures, functional neurologic disorders, which are receiving a lot of interest, a topic near and dear to my heart, but we won't be discussing them today. Anti-seizure medications and epilepsy are linked to suicide, which is a controversial topic that we won't get to cover today in detail. And it sparked a lot of controversy in the past. Obviously, there's a relationship between psychiatric disorders and suicide as well. So there you go, another area of overlap. And there are other phenomena as well, including the potential for violence and cognitive dysfunction caused by both epilepsy and neuropsychiatry, and psychosocial stressors leading to psychiatric maladies and impacting epilepsy outcomes. And as you can see, all of these arrows are two ways presenting you with a complex relationship between epilepsy and neuropsychiatry. So let's try to go over some of all of this in the 30 or so minutes that we have. Let's start with the case. This is a 56-year-old right-handed lady who had a possible history of remote TBI, of which details weren't clear. She was brought to the ER confused right after a convulsion. And family tells us that she had had peculiar stereotyped episodes of visual hallucinations. These were described as seeing a black man sitting in the corner staring at the patient. This in our community in Saudi Arabia, where I practice, often invokes the idea that there's jinn possession. She was taken to faith healers and so on and so forth. When you dig deeper in the history, people tell you that she would sometimes have shaking episodes, vocalizations, and display fear, all of which also fit in the narrative of being possessed. And she had intermittent cognitive dysfunction as well, with inability to recognize her family members. So when we came to our emergency room after the convulsion, we did the EEG, and it shows obviously right temporal seizures with evolution of sharp activity and rhythmic delta activity, and she was treated as epilepsy, and that led to resolution of all of her symptoms that were allegedly explained by possession. So the first lesson is that neuropsychiatric symptoms contribute to the stigma of epilepsy. Epilepsy has long been known to suffer, patients with epilepsy, individuals with epilepsy have long been known to suffer from stigma in various aspects. There have been increased awareness in our region, a lot of programs. The Saudi Epilepsy Society, for example, leads a lot of programs combating stigma. And neuropsychiatric symptoms, just like the rest of neuropsychiatry or psychiatry in general, also suffers of stigma. So when the two combine, that leads to a double whammy. I looked at some of the determinants of stigma in our region, and I found out that I was interested whether the way people think of where our behavior and where mental functions come from had an impact on how they thought of epilepsy. And so I had a questionnaire where I asked people how they thought about the self and the soul, and whether these entities were able to overcome brain or biological factors determining behavior. And obviously, and as expected, and as is in many other communities, there were a lot of people who were dualists, meaning that they think that there are two types of, or two main causes of human behavior, one of which is non-physical or non-biological. And what I showed, and this is published in Epilepsy and Behavior, is that this perception of mind-body dualism of non-biological factors leading to human behavior is directly linked with stigma toward epilepsy. So it is not religiosity and is not supernatural beliefs per se. These are mediating factors, whereas the important determining factor here is the philosophical stance. And this may be important in informing how we combat stigma in our region. So we have I'm looking at a model currently where all of these various factors are important, but where the people's philosophical stance with regards to how human behavior is instantiated serves as a central factor. Moving on to the next lesson from the next case, somewhat similar, a 23-year-old right-handed man. He was diagnosed with panic disorder and was referred for evaluation for treatment-resistant panic attacks. He would have sudden bouts of crying, along with experiential phenomena and depersonalization. He would have a little bit of what you would see with panic attacks, breathing difficulty, tachycardia. He also had classical things that you would see with idiopathic panic disorders, such as agoraphobia. He had a lot of family stressors as well at the time. He was treated with venlafaxine, with some but not complete remission of the symptoms. And we got an EEG, which demonstrated interictal discharges independently in both temporal lobes, with some rhythmic activity as well in the right temporal lobe demonstrated here. And here are more examples of his interictal discharges. And the MRI showed periventricular nodular heterotopias, gray matter in places where it shouldn't be, known to be one of the conditions associated with epilepsy. So we treated him with lacosamide, which led to the disappearance of many of his short-lived panic-like episodes, but with persistence of anxiety, of more long-standing chronic anxiety symptoms. So the lesson one can glean from a case like this is that one should listen carefully to the semiology and be wary of the overlap between seizure symptoms and idiopathic psychiatric disorder symptoms. As a matter of fact, 25% of our focal aware seizures present with psychiatric symptoms, and 60% of these are predominantly, we commonly see that in our epilepsy monitoring units, is ictal fear, ictal panic and anxiety, and mood disorders come second. Temporal lobe epilepsy in particular overlaps with panic disorder to a great degree, and depending on what series you look at, the rates of misdiagnosis of temporal lobe epilepsy as panic disorder initially may reach as high as 20%. And if you listen carefully, sometimes or most times you're able to differentiate the two. Fear in ictal panic is briefer, whereas in panic attacks, it lasts the classic 15 to 20 minutes. It's dramatically intense fear, that is, in idiopathic panic disorder, whereas it's less intense in people with panic attacks. Although this is not always clear cut. One patient immediately comes to mind who was sitting in our epilepsy monitoring unit and suddenly started yelling, "My father, my mother, my family, my parents," as if, the world was coming down. It didn't make sense at all, but neither do idiopathic panic attacks. In association with both as well, there's autonomic hyperactivation. There's tachycardia and hyperventilation. But some of the stuff may also be distinguishing. So increased salivation and nose wiping, sialorrhea, are rarely seen with idiopathic panic attacks. Both are associated with abnormal motor phenomena. Automatisms are seen with temporal seizures, obviously, and psychomotor activity is seen in idiopathic panic attacks, and the two are different. And nowadays, it's helpful to have people just pop up their phone and take videos of their loved ones if they happen to see a seizure, and that may help as well. And so on and so forth, going down the list, there are key differences that that clinicians can use to differentiate ictal panic attacks from non-ictal panic attacks. All right, and there are many examples of ictal behavioral manifestations, seizures leading to behavioral manifestations, absence seizures being a very common example, masquerading as ADHD or even as misdiagnosed as psychosis in certain situations. Temporal lobe seizures, like I mentioned, present with anxiety and panic, but they can also have other manifestations, including audiovisual hallucinations, experiential phenomena, déjà vu and jamais vu, or ictal aphasias. Frontal lobe seizures are also present with ictal behavioral manifestations. Obviously, we're highlighting the behavioral manifestations here and not going into the non-behavioral manifestations of these seizure subtypes. Frontal seizures may present with manic-like states, altered behavior, forced thoughts, alteration in mood, impulsivity, or the other end of the spectrum, a loss of interest in doing things, a Bulic-like states with preserved awareness. And you may also have frontal absences with impaired awareness, lack of interaction with the surroundings in a dialeptic-like state. And rarely people present with agitation or aggressiveness leading to injury of self or others. And neurologists like to always localize. So we can always think of the syndromes that present with various seizures, but it helps to remember the behavioral neuroanatomy. If you remember that the mesial temporal lobes are responsible for fear states and mood regulation, and they're the link to the autonomic nervous system, you'll remember that some of these may be seizure manifestations. And I highlighted some of the helpful ones here. So salivation, for example, is something that you don't routinely see with non-ictal fear states. Piloerection is something else that if it happens asymmetrically and you're able to get a report of it, could be interesting and lateralizing to the dominant temporal lobe, for example. Erotic manifestations are in the right clinical context and with a history that is reasonably attainable, since it is a difficult topic to discuss with many of our patients, is also lateralizing to the non-dominant hemisphere in this case. If you remember that the lateral temporal structures are responsible for audition and language and complex visual perception, you may deduce that they are responsible for, they may be responsible for these seizure manifestations. And going down the list, if you remember that the mesial frontal lobe is responsible for volition, a sense of wanting to do things, as well as a sense of self and others. And it is a part of the limbic system. Think of the cingulate gyrus lying there. You'll remember that some of its seizure manifestations may include alien limb-like phenomena, ictal pouting in a disgust-like state, is often referred to as chapeau gendarme, and so on and so forth. And laughter, mirthless or mirthful, may also be an interesting presentation here. The lateral frontal lobe is perhaps one of the most blamed for many of the bizarre behaviors and sometimes misdiagnosed as psychogenic seizures because of how bizarre and unexpected, given the fact that the frontal lobes are responsible for the most high order processing of behavior. The orbitofrontal cortex is responsible for inhibition and emotional processing, as well as autonomic processing, and therefore you can link some of these seizure manifestations with those functions. Most important of all is remember that epilepsy is a network disorder, and that we're speaking about temporal and frontal regions, which are highly interconnected, and therefore it is important to analyze when symptoms started and how that is linked temporally to your EEG, either scalp or intracranial. We didn't speak about psychosis or mention it yet, and that's possibly because neurologists don't like syndromes. We break down things into their neurological underpinnings, and there are a lot of reports linking psychosis as a syndrome with temporal lobe epilepsy, with some of these psychopathological entities being in the descriptors. And it is known that there's an increased risk of epilepsy in people with psychosis and with temporal lobe epilepsy in people with psychosis, and increases of psychosis in people with temporal lobe epilepsy. So there's a two-way arrow. And this is perhaps a segue to this next case, a 40-year-old right-handed man who had long been diagnosed with schizoaffective disorder and who had a shaking episode with loss of consciousness and he had an EEG right after that, in the context of being treated with a little bit of valproic acid for mood and clozapine for his resistant schizoaffective disorder. And you can see that after that episode, he had this seizure with buildup of beta waves that evolve over time in the right posterior quadrant and clearly present themselves as seizures. So what we did for him is that we optimized his valproic acid, ended up adding lamotrigine, and discontinuing clozapine. His seizures were controlled. He no longer had any of those spells. His EEG improved at the time, and he clinically improved as well, not just in terms of seizures, but also his psychosis having improved better than ever. And the lesson to glean from that is that non-convulsive seizures and even status epilepticus may present purely with neuropsychiatric symptoms. And even though perhaps 90 out of 100 times your psychiatry colleagues or your other neurology colleagues raise the possibility of a particular psychiatric syndrome being ictal or seizure related, there are going to be these cases that you will miss if you didn't keep this lesson in mind. And it has long been known that neuropsychiatric symptoms may be seizure related. This is from a paper by Peter Kaplan demonstrating, if you go through demonstrating or listing the symptoms of non-convulsive seizures, and there's so many of this stuff that is just purely behavioral or cognitive or psychiatric. So people can present with fluctuating episodes of behavioral disturbances, or can have their typical seizures with, and if they cluster, they start having these psychiatric symptoms in between. And you can see anything from confusion to delusions to hallucinations. Religious ideation has been described a lot in temporal lobe epilepsy, ictally and interictally, and so on and so forth. And this is from an old series, but you can see that all kinds of, it's the same kinds of epilepsy that are blamed for, that we mentioned previously: absence seizures, temporal lobe seizures, and frontal seizures. Our next lesson is that we must differentiate ictal, interictal, and postictal neuropsychiatric symptoms. Like I said, we won't speak about interictal neuropsychiatric symptoms, but the lesson that we're going here is that we're going to have to learn and remember that there may be an overlap between ictal and postictal neuropsychiatric symptoms. Let's talk about postictal psychiatric symptoms. There are immediate postictal symptoms, including confusion, delirium. People can get agitated sometimes after their convulsion or after their prolonged focal unaware seizure. And there are delayed postictal symptoms, including postictal depression, most commonly, or mania or psychosis as being seen less commonly. Postictal psychosis received a lot of attention. And, these are the famous criteria of Lonsdale and Toon, time-tested. And they argue that there should be a return of apparent normalcy of mental functioning after the seizure for you to be really sure that this is the entity of postictal psychosis. They do include immediately emerging symptoms as well as postictal psychosis, but what they've referred to as nuclear or the core postictal psychosis requires a period of normalcy. The idea is that postictal psychosis is a Todd's-like phenomenon of behavior regulation and thought regulation areas, generally speaking. Just like you may have a paresis of your right body after a left brain seizure, you may have disorder of your thought, psychosis, after a seizure of those areas. And what we think right now is that this nuclear postictal psychosis requires the presence of a lucid interval after the seizure cluster, and that if there is no lucid interval, this psychotic state may in fact be ictal or periictal, or on a continuum of being ictal post-ictal. And obviously the treatment differs here because, in this situation, you would treat with psychotropics, whereas here your focus needs to be on stopping those seizures. And this is what I was referring to earlier. If you have a lucid interval and you have complete psychotic criteria, then you have nuclear post-ictal psychosis. Whereas if there is no interval, there you're risking being in aura continua, a state where there is continuous seizures leading to psychotic symptoms. And this was demonstrated in many published cases, and this is our attitude in anybody who comes in with a convulsion. We look for non-convulsive seizures, and that includes looking at treating people until they return back to baseline, and that includes looking for psychotic symptoms as some of the manifestations that you may expect. And this is one that, this is a case of a 4-year-old man who was having intracranial monitoring, who had psychotic symptoms with intracranial EEG showing activity, ictal activity in what was deemed post-ictal previously. And this is sort of akin to what has been the predominating thought over the past couple of decades in ICU EEG, where we have a spectrum between interictal and ictal phenomena. In other words, what you see in the context of seizures or immediately after seizures, either electrographic or clinical, may in fact be ictal, even though one would think they're interictal. All right, on to the next case and the next lesson. Case 4 of a 23-year-old man who had episodes of abnormal behavior and loss of consciousness and some shaking. He was brought to the ER with a convulsion. He was treated with levetiracetam, went back to baseline, went home. After 10 days, came back with a chronic, with a constant psychosis that didn't leave him. He was admitted to the EMU. He had normal EEG, and take a couple of seconds to think what you would do. Would you think that this person had another seizure that you don't know? What do you think that his EEG, his psychosis is ictal? These are all reasonable things. But one thing not to forget is that you introduced a variable here, which is treating with levetiracetam. And that's what we did. We took him off of levetiracetam. He came back, he improved over the course of the next couple of days. And upon follow-up, a couple of weeks after, he was completely free of psychosis. So one must choose the medications with not just the seizure outcomes, but also the neuropsychiatric outcomes in mind. And for the sake of time, I elected to just present this simplified list. There are meds that may hurt our neuropsychiatric outcomes, leading to psychosis, for example, or depression, worsening anxiety, or leading to cognitive dysfunction. Obviously, these meds listed here are different in their profiles, but I'm just trying to present you with a pearl. Phenytoin and phenobarb are notorious for their narrow therapeutic range, and both may lead to sedation and psychosis, even in the normal, quote unquote, normal range. Levetiracetam has become widely used, perhaps the first line medication for many of our patients, but there's the 10% that get irritable, and there's the 1% that get significant neuropsychiatric complications related to levetiracetam use. Breviracetam may have a better neuropsychiatric profile. There's data pointing towards that, but that's yet to be confirmed. Topiramate is well known for causing cognitive dysfunction. It has also been linked to increased risk of psychosis, as well as zonisamide. It's it's a closely allied compound. Perampanel, the no longer new kid in the block, is well known to, in a minority of cases, lead to irritability, suicidal or even homicidal ideation. So these things are, these meds may hurt our neuropsychiatric outcomes. These meds here may be helpful. So valproic acid is used for the treatment of bipolar disorder, for example. There's, of course, the link between valproic acid and urea cycle disorders and the subsequent encephalopathy, but that is a rare occurrence. And valproic acid typically has a positive effect on mood. However, I don't mention valproic acid without mentioning that it shouldn't be used in females, especially in our female patients, without a careful discussion of its associated significant side effects otherwise. Carbamazepine, oxcarbazepine are also used for mood regulation. Lamotrigine has an antidepressant effect and is used as an antidepressant in bipolar disorder. Gabapentin, pregabalin are helpful for anxiety and for sleep. Lacosamide is not really helpful in my experience, but it does not carry the same level of neuropsychiatric complications that are seen in those in that proportion of patients that we give levetiracetam to. And it is also important to consider the seizure threshold effects of some of our psychiatric medicines. Bupropion is a very helpful antidepressant medication, and it has been linked with an increased risk of seizures with lowering of a seizure threshold in a proportion of patients. The sustained release formula carries less of a risk in comparison to the immediate release formula. The rest of the antidepressant agents are either seizure neutral or slightly anti-seizure, depending on what series you look at. The other highlights from this systematic review is that alprazolam, the short-acting benzodiazepine, is associated with an increased seizure risk. One can easily imagine how withdrawal can have a role there. Clozapine, the effective antipsychotic medication with a lot of side effects, increase or reduces your seizure threshold and increases the risk of having a provoked seizure, as well as clomipramine, the tricyclic often used in patients with obsessive compulsive disorder. So one wants to keep an eye out for these medications. Here's the next case. This is a patient of mine who presented with medication refractory left temporal lobe epilepsy, where he had an episode of postictal psychosis where he was a little agitated. He was more flamboyant than usual at baseline. He's a very nice guy. And we proceeded with a left temporal lobectomy in this patient. He continues to be seizure-free. His course post-surgically, though, was complicated with a mania. I remember this guy showing in clinic with his wife, who has been very supportive of him. And when he got manic, the first thing he wanted to do was he wanted to go have affairs and so on and so forth, which was highly uncharacteristic of him, along with the rest of what you would expect from somebody manic, including overspending and impulsivity and grandiosity and so on and so forth. And we looked at his brain with DTI, and we published a hypothesis that we think that one of the reasons why he got into mania was because of dysfunction of the uncinate fasciculus and the coordination of mood between temporal and frontal regions. Time doesn't allow us to go into details. The lesson here is that there are post-surgical mood disturbances. And even though temporal lobectomy and anterior temporal lobectomy epilepsy surgery, if done carefully, is associated with improved quality of life and even an improvement in psychiatric outcomes in a third of patients, there are variables that may increase the risk of post-surgical mood disorders. Immediately post-surgery, depression and anxiety is seen in up to half of patients, almost, and mania and psychosis are seen in a minority or in a smaller proportion of patients. And this is from a series by Karen et al. Showing some of the variables associated with the emergence of post-ictal depression and mania. What we want to highlight here is that the non-dominant hemisphere surgery or non-dominant anterior temporal lobectomy is a risk factor. But the most important risk factor perhaps is the presence of pre-morbid or pre-surgical psychopathology. And for the interest of time, I will take you one slide further, and I'll show you that that's actually not a small proportion. And hopefully we'll cover some of the comorbidities, psychiatric comorbidities in the next talk. There's, depending on what series you look at, up to 3/4 of your patients with epilepsy, many of whom are surgical candidates, will meet criteria for many psychiatric diagnoses. And the presence of this psychiatric morbidity increases the risk of post-surgical psychiatric complications. And sticking to time, here are your take-home messages. There's a clinically relevant and long recognized overlap between epilepsy and neuropsychiatry. Seizures may present with psychiatric symptoms and may be misdiagnosed as psychiatric disorders. Semiological analysis and listening to patients, like always, helps. Localization of neuropsychiatric symptoms contributes to accurate delineation of the epilepsy diagnosis. Localize, and be neurological. Status epilepticus may present purely with neuropsychiatric manifestations, like we illustrated. There is a continuum between ictal and post-ictal neuropsychiatric symptoms, specifically psychosis, and treatment is different. Now remember the presence or absence of that lucid interval, differentiating people who have a higher risk of being on the ictal-interictal continuum and those who just have post-ictal cerebral dysfunction. It is important to consider neuropsychiatric effects of anti-seizure drugs and seizure threshold effects of psychoactive drugs. Finally, pre-surgical neuropsychiatric morbidity in surgical candidates is considerable, is a predictor of post-surgical psychiatric complications, and that must be considered along with potential seizure outcomes and cognitive outcomes that are always in the back of our minds. We should also keep neuropsychiatric outcomes in the back of our minds. This is where I'm from. This is King Abdulaziz University Hospital, where I had the epilepsy unit. We're particularly interested in neuropsychiatric and cognitive aspects and are trying to do some work in collaboration with my with colleagues from other institutions in the region. This belongs to King Abdulaziz University Hospital University. Proudly sits on the top of ranking in the Middle East. I work with a group of distinguished colleagues. Time doesn't allow me to mention their names or tremendous contributions. I also work with amazing colleagues at the Saudi Epilepsy Society, and the Saudi chapter of the International League Against Epilepsy, and the Saudi chapter of Cognitive and Behavioral Neurology, who have a lot of work related to Alzheimer's these days, but are also interested in neuropsychiatry, especially with focus on epilepsy. I look forward to the discussion. Thank you for the opportunity, and thanks.
Thank you very much, Dr. Haytham Tayyib. It was a very interesting presentation, especially for me as a psychiatrist. I really learned a lot, and I invite everybody who has a question to write their questions in the discussion session, and we will see them later on. And as we are waiting for the questions of all participants, I have one question in mind, and I would like to have your point of view.
Yep.
You know, as I said, I'm a psychiatrist, and we often have to examine patients suffering from panic attacks or from acute psychotic symptoms. And for example, for panic attacks, or even for acute psychotic symptoms, we don't usually perform systematically EEGs for such patients.
Yeah.
What we perform systematically are biological
Right.
exams, brain imagery, but not necessarily EEG. So I would like to have your point of view. When should we absolutely perform an EEG? It depends on what features does it depend on the patient profile? Does it depend on the symptoms themselves? So
Yeah.
I would like to have your point of view. Thank you.
Yeah, thanks for the question. I love working with my psychiatry colleagues. They always call me the psychiatrist wannabe. I think it always comes down to how comfortable we are that this patient presents with just the typical, say, for example, panic disorder with, say, for example, some of the elements, the preoccupation between episodes, the behavioral response, the clarity of, how one deals with the episode and so on. And then there's also those little things that, I highlighted as differences between the semiologies, such as salivation and sialorrhea and so on and so forth. Family history also helps. I think it's easy to get an EEG. People get overwhelmed with EEGs, though. And sometimes, having said that, sometimes we even argue for invasive monitoring with foraminal valley electrodes, for example. And, it all depends on how the patient responds, and every case is different. But if I would always ask myself, is this, I see patients with panic disorder along with my colleagues, and I always ask myself, does this sound typical? Does this sound typical? Does this sound typical? Are there risk factors? What is the likelihood that this is not panic disorder? Because, unfortunately or fortunately, this remains to be a diagnosis of exclusion. If you look at the criteria, you have to demonstrate that this is not something else. So you always look for that, and, you look for the red flags. And if you've managed to convince yourself that there's one red flag, please call or get an EEG. Yeah.
Thank you. Thank you. I guess we have another question here. There's Mr. Faisal Al-Lutaibi, who says, many thanks for this outstanding talk, Dr. Haytham. From your expertise, what is the best way to approach a patient with non-epileptic and epileptic seizure related to pure temporal lobe epilepsy pre-surgery?
Faisal is the head of the Saudi Epilepsy Society in the international, the Saudi chapter of the ILAE. So he's indulging me with this question. So thank you. It is an interesting question, though. What do you do with non-epileptic seizures when you're considering epilepsy surgery? It depends on whether this is temporal or extratemporal. I think it is important to delineate which events are epileptic and which events are not epileptic, so that people know which events are likely to go away with surgery or not go away with surgery. There are reports of worsening people with mixed presentations, with their epilepsy getting better, but with their psychogenic non-epileptic seizures getting worse. And people need to know that as well. and it's in line with the presence, the 2/3 of people with pre-surgical morbidity that don't improve in terms of their psychiatric outcomes post-surgically. So people must know this well in advance. And the problem is that with cognitive outcomes, you could do a WADA, you could do fMRIs, you could tell people, you could give people a more educated guess with regards to how their outcomes are going to look like. With psychogenic seizures, people just need to, be comfortable with the idea that their psychogenic events are not going to get better and may in fact get worse. And it just needs to be a candid discussion. I think, though, that this shouldn't necessarily deter people from doing epilepsy surgery. Because there's also the flip side. The improvement in quality of life may have indirect effects on the occurrence of functional neurologic disorders in general. And therefore, this needs to be one of the factors, but should not be the determining factor. And every case is different. Depends on how this person works with therapist, and depends what the psychiatric comorbidity is. So a candid discussion, I guess, is what would summarize my answer to the question. Thanks, Faisal.
Thank you very much. I guess we have another question here. Mr. Ghayeb Al-Jandi is asking the following question. Is there a possibility of coexistence of the two, epilepsy and psychiatric illnesses, that are not related to each other?
Yeah. As comorbidities, so you have epilepsy, and you have your seizures, you have periictal seizure manifestations, and then you have interictal stuff that we didn't talk about today. There's in fact entities that look exactly. So one of the examples is schizophrenia-like psychosis in epilepsy. This is a schizophrenia-like disorder with no family history, with less negative symptoms than usual. That is seen in people with epilepsy who have uncontrolled epilepsy after a long time. So interictal psychosis is some of the stuff that we didn't talk about. And it all comes back to my first slide with the lesion being shared and the localization being shared between many of our epilepsies and what we think are the localizations of psychiatric disorders. So the answer is yes. I also showed that slide talking about how prevalent psychiatric comorbidities are in people who are surgical candidates. So that's another piece of data that is helpful. And hopefully the next talk will highlight some of that as well.
Thank you. I guess I would like to ask you a last question. Well, it's not really a question; it's rather an advice. I'm asking for an advice, actually. I don't know whether you are asked to make a forensic to work in a forensic context for epileptic patients.
Sometimes, yes.
And I think for me as a psychiatrist, forensic context, when we have an epileptic patient, is one of the most challenging situations. I mean, yes. Last time I was on duty, I was asked to examine a patient who was 26 years old, and who suffered from epilepsy from the age of 5. He was taken valproate, and he aggressed someone else. It happened 1 month and a half before I had to see him, and I was asked to say whether it was because of his epilepsy or because of psychiatric symptoms related to his epilepsy, or he was just responsible for all he did. And I think it was a challenging situation for me, and I don't know whether you have helpful tips in such situations for a forensic context. Thank you.
Yeah, these are some of the most fantastic and some of the most complex cases.
Yes,
Um,
indeed.
the link with violence and crime has long been discussed in epilepsy. There are a lot of papers out there, and it's in the context of um, you know neuroscience being, nowadays neuroscience is coming more and more into the courts worldwide. Um, but specifically for epilepsy, uh, it is often very hard to demonstrate that a patient with epilepsy uh, commits a crime because of a seizure, an ictal crime, or ictal violence. That happens. Post-ictally, people can get agitated, people can get psychotic, and but people, crime and violence requires meditation, requires planning, requires executive functioning, requires weighing of priorities. There's a certain degree of anxiety, oftentimes. Um, I'm not a criminal, but even if I sound like one right now, but a lot of these things are highly coordinated functions. And if we go back to that table I showed about the behavioral neuroanatomy, you'll see that perhaps the one that comes close to all of that is if you have a lateral frontal seizure, for example, with some of the bizarre behaviors. Um, and, you know, um, in that case, you can sort of ask yourself, is this deliberate or not deliberate? Like I said, some of these patients get misdiagnosed with psychogenic seizures. So in this context, I think one wants to look carefully at motives and about the description of what happened. In one of the cases, or I had to look at hours and hours of video footage of a cellmate and what they did before hurting somebody. Um, that patient turned out to have epilepsy, but it had nothing to do with him committing the crime. So, if you go through the behavior itself leading to the crime and you examine it in the context of whether this is related to ictal behavior, which is, I think, extremely hard to prove, and almost impossible, I think, or post-ictal behavior, I guess that's a little bit more likely, but it's so disorganized most of the time that it doesn't lead to crime, or interictally, in which case, what kind of interictal disorder is it? Is this person completely psychotic? People with schizophrenia can commit crimes. People with mania can commit crimes, in which case you want to, that better than me. So if people are completely manic or completely psychotic, this can be taken as a mitigating factor for their quote unquote responsibility and free will. So, I gave a complex answer because this is a complex, because a complex question. These are complex cases, but to simplify, I always like to simplify after I just give a nonsensical, completely jargonified answer, which is that most seizures are not. Most people with epilepsy do not commit crime. Almost everybody with epilepsy or all seizures are not coordinated enough to lead to crime. And accidents can happen, but it's very difficult to prove that an ictal phenomenon led to deliberate violence.
Okay. Thank you.
Yeah.
Thank you very
Thanks
much.
for the question.
Thank you. We have another question from Mr. Ghaib Al-Jandil, who says, do you prefer to limit the use of levetiracetam as to its occasional behavioral complication?
Well, all medications have side effects. So what I do is I just consider, if I have somebody, say, suffering from depression or had a history of depression or strong family history of depression, or is irritable, I don't choose levetiracetam. So you always tailor your medication choice to the patient, and that applies to levetiracetam and to everything else. I think it is still probably, I think from our practice, is probably the most prescribed anti-seizure medication, levetiracetam. There are many, the hepatotoxicity is rare. You can adjust the dose in renal dysfunction. It's available in IV, helpful in status, demonstratedly. You can get to your therapeutic dose in a couple of days. So it's a very useful medication. You don't need monitoring and so on. So it is still widely used. I do tell patients, though, that a proportion of patients, perhaps 10%, will get irritable. So you want to tell me if that happens. There are things to do when that happens. Sometimes we have to change the medication. But if you don't choose levetiracetam, you're going to have a similar talk about rashes with lamotrigine, or the risk of, say, psychosis or cognitive dysfunction with topiramate, and so on and so forth. So it's just one of the side effects that you want to talk to your patients about, but does not necessarily limit, as the question says, my use of levetiracetam.
Thank you. We have not really a question, but rather a compliment. Mr. Faisal